Good evening, good afternoon, good morning, wherever you are in the world. Salam alaikum. My name is Leigh Holtzhausen. I'm the director of the Aspetar Sport Concussion Program, and it's my pleasure to welcome you to our online forum today, where we'll be discussing complete concussion care from club to country. Concussion has arguably become the hottest topic in sports medicine in many decades. Seldom, if ever, has there been such public interest and media interest in a sports injury as there is for concussion right now. This interest is often reflected in criticism against organized sport and against sports physicians because of perceived poor management of concussion that people witness on television. Now, this criticism is sadly, unfortunately, very often deserved. The sports medicine fraternity has come a long way, especially in the last 2 decades, to improve our understanding and our management of this difficult injury, which turned out to be not so very innocent as we previously thought. Yet, even with really good, if not perfect, concussion management pathways and guidelines in place right now, it's very difficult to convince stakeholders in sport to adhere to the best evidence that we present and we're trying to implement in our clubs. And there are many reasons for this, including the fact that concussion often present with vague symptoms, and it's sometimes very difficult to make a decision and a diagnosis of concussion, especially in the heat of the moment. So today we invited a panel of experts to discuss the solutions in implementing concussion care from club to country level, at all levels really of sport. And to tell you more about our forum today, it is my privilege to introduce my co-host this evening, Professor Jon Patricios, who's Professor of Sport and Exercise Medicine in the Faculty of Health Sciences at the Wits University in Johannesburg in South Africa. Welcome, Jon, and thank you. Over to you.
Thank you very much, Louis, and a very good evening, good day to everybody who's out there. And a particularly warm welcome to our colleagues who've joined us from around the world and our panel this evening. Louis, thank you for initiating this forum, which I think hopefully over the next 2 hours will be very informative, and to Aspetar for hosting us as a panel this evening. And we really look forward to the engagement over the next 2 hours. So the idea of this evening is really to leave with some very practical ideas of how to install a program or a support process of best practice in clinical concussion care in your own environment, whether that's in a school, a university, a club, a provincial setup, or perhaps even at national level. And to do that, we've put together a panel which we think is going to provide very informative information in terms of best practice that's out there. And so it's a great pleasure really to introduce the speakers which we have and the topics they're going to present. We're joined this evening by a colleague of mine, a South African colleague, Dr. Leigh Gordon, who's in Cape Town. And Leigh has really been at the forefront of implementation of best practice in rugby union in South Africa. And she has worked in the men's and women's games. She's worked at all levels of the game, has currently come back from the sevens tournament in the Olympic Games. And she has really worked at implementing the highest level of care as dictated by the Concussion in Sport Protocols and World Rugby. So Leigh's going to really talk to us about how she's managed to do that and the key principles in terms of implementation from community level right through to international level. I've then been very privileged to have been introduced to Dr. Raouf Rekik, who is based with Dr. Holtzhausen in Qatar, and he's going to look at some very real life scenarios that he faces as a club doctor in the implementation of best practice of concussion, particularly in professional football or soccer, where he works in the local league. He manages a team, and he really has put together a network that manages the protocols that are implemented. So we're really looking forward to that presentation and the discussion with Dr. Rekik in terms of his real life experience on the ground in soccer concussion management. Then we have from Calgary in Canada, Carolyn Emery, who is really one of the foremost experts in the world in terms of concussion prevention strategies. You will see in her presentation some outstanding research that's been done by her team in Canada at many levels of the game and in a number of different contact and collision sports. I'm very privileged to be working with some of her team on a research project looking at video analysis of injuries, concussion being one of them at the moment. And she has really put Canada on the map in terms of assessing preventative strategies. And Carolyn's team really has a significant input into the concussion in sport consensus process in this regard. So we're really looking forward to that presentation. And then we're going to wrap up with a presentation from Dr. Holtzhausen himself, who's going to give us an outline of how he's implemented best practice at Aspetar Sports Medicine and look at the Aspetar Sports Concussion Program. And it's perhaps fitting that Louis ends off as we look forward to the FIFA World Cup being hosted in the vicinity there. And I'm sure many of these protocols will be in place at that tournament. So it's going to be a very exciting evening. I'm looking forward to learning a lot, and particularly at the end of the evening to engaging in the panel discussion with all of my colleagues, where we hope to interact and answer many of the questions which you have, I'm sure, in your minds out there, and hopefully, as we say, leave with some practical ideas of how to implement these best practices in your environment. Thank you, Louis. I'm going to hand over to you to introduce the various talks.
Thanks, John. So my first job in this regard is to introduce you as our first speaker. I will do that. Jon Patricios has been a sports medicine physician for over 25 years, as I mentioned earlier. He is a professor of sport and exercise medicine at the Wits University in Johannesburg, in South Africa. More related to concussion, he's also the founder and the director of Sports Concussion South Africa, and he serves on many national and international bodies, including the Concussion in Sports Group. He's also a concussion consultant to World Rugby, so really a world leader in this. And I have to say we are proud to have Professor Patricios as the consultant to the Aspetar Sports Concussion Program. So to introduce this evening's proceedings and give us an overview of the current state of concussion care, I hand over to Professor Jon Patricios.
Good evening, Louis. Thank you very much for that introduction, and thanks also for the invitation to present with this esteemed panel as part of your Aspetar Concussion Education series. I'm going to proceed straight away and share my screen. Hopefully you can all see that, and I'm going to in the next 15 to 20 minutes just really fulfill my brief, which is to talk about where we are in the state of play of sports concussion management at the moment. And we're going to start off like we always do with a definition. And I think we've all now come to realize that the sort of modern definition of concussion is very different to what it was when I started training and when I started looking after concussion in collision sports. And broadly speaking, we now talk about a trauma-induced change in mental state that may or may not involve a loss of consciousness. So that's significant because it really is a very much broader definition than we used to have. And that change in mental state is a change in function of the brain, which spans a number of different areas or domains, as we'll cover later. And if we talk about concussion, it's really at one end of the spectrum of traumatic brain injury, the sort of minimal to mild spectrum of brain injury, which might seem insignificant, but in fact, it's exactly the opposite. Because it's at this end of the spectrum, it becomes much more difficult to identify and manage in many cases. The pathophysiology really revolves around what happens in the axons or neurons, billions of them in the brain in very intricate networks, and what happens at the synapse in terms of transmission of signals along nerves and then between nerves. And if we look at these slides put together by Bob Cantu in Boston in the United States, we see that the change in concussion really comes about as a result of an efflux and an influx of different ions, which have a toxic effect on the neurons and significantly alter the ability of those nerves to conduct signals and also to transmit signals between different cells. And that massive change in the electronic signaling across and between cells has a significant impact on brain function in various areas of the brain. It leads to what we call a metabolic dysfunction and energy crisis, where a cell that's in distress also has limited access to the energy available to try and repair those cells and try and bring the physiology of the cell back to normal. In this particular state, it's extremely vulnerable, and so it's really, really important that we protect the cell from further damage in this particular state. The good news is that in most cases, this tends to reverse, and after days or weeks, sometimes months, we tend to return to a fairly normal state of normal function. More graphically represented here, we see the potassium and calcium ion changes, the initial increase in glucose requirements, the initial decrease in cerebral blood flow, and the changes in those neurometabolic cascades that eventually come back to normal, should come back to normal, to result in resolution of the concussion. What we're not sure of is how long this takes and how closely the pathophysiological changes match the clinical manifestations. And that's one of the challenges for the clinician, because it's very difficult, in fact, it's impossible to measure this. We really rely on those functional changes which are apparent to us in the clinical assessment. And that's why the clinical evaluation is so important. There are a number of papers which look at this pathophysiology in a lot more detail, and I'd challenge you to go and read some of these papers, particularly this one by Erin Kenzie from Frontiers in Neurology, which very eloquently describes the complexity of concussion at multiple levels, looking at that ionic flux and the axonal injury, which we've just discussed, but taking it further and placing it in several contexts in terms of the network of those cells, and then looking at various personal and injury contexts in terms of the social context of that concussion. So concussion is a very, very complex injury. And the difficulty, of course, is that there's no visible wound. So it's very difficult to identify often and to manage it and to see how that concussion is progressing. It takes really quite good clinical acumen to be able to determine the complexities of what's going on in the brain. So we're not going to be able to cover that in the next 15 to 20 minutes, but I thought it was important to allude to it, to make sure that we don't dumb down the concussion too much, and we appreciate the complexities of what we're dealing with. And those complexities really involve a network of billions of neurons in various areas of the brain that affect many areas of brain function. And that results in the presentation of signs and symptoms in a whole range of what we call subtypes or domains. So these may be physical or somatic, and I think we're really familiar with many of those symptoms. They may be cognitive, affecting the ability of the brain to think. And perhaps we acknowledge not enough the emotional and sleep and energy types of manifestations of concussion. But it's important to recognize the spectrum and to interrogate the spectrum of concussion that may present. It's also important to have a significant awareness. Although we are probably cognizant of the possibility of concussion in contact and collision sports and team sports in particular, there are many, many scenarios in which concussion may occur. And we need to be very aware of this and make sure that we treat them with the same level of awareness that will result in complete concussion care and complete recovery. Now, what we discuss in all of our presentations this evening really emanates from a series of consensus meetings, the last of which was held in 2016, and the most recent of which should have been held last year and then again this year, but because of the pandemic had been postponed. This is important because this is expert opinion and science that emanates over a 4 or 5 year period and then is pulled together in a consensus meeting where that science is really sifted through and the key aspects are put into the clinical protocols which we speak about. The consensus papers which emanate from these meetings are published in the British Journal of Sports Medicine, and the 12 papers, the systematic reviews which emanated from the last meeting are freely available on BJSM. The International Consensus Meeting from Berlin had 11 key messages, the 11 R's, which are summarized on this slide. And these are very important because they really allude to the key areas of intervention, the key inflection points in the recovery of an athlete who has sustained a sport-related concussion. And it's important to move through all of these and make sure that as a clinician, whether you're working with a football team or whether you're seeing a patient in the office, that you make sure you do a thorough evaluation and cover all of these aspects. Very important is knowledge translation. And we're very, very fortunate in having experts available to us who help us in this area. It's all very well having consensus meetings and summarizing the science available, but how do we make that accessible to clinicians and even more importantly to athletes as well? So that knowledge translation is important, and I would like us to come out of this seminar with a better strategy as individuals and as team members as to how we translate that science. That science is obviously evolving and doesn't stop at 2016. And over the last 4 or 5 years, we've had a number of key areas which have been investigated and looked at and which will feed in and are feeding in to the way we assess and manage the concussed athlete today. The current process that we're going through in preparation for the next consensus meeting is one of evaluating the key areas of concussion, 10 or 12 key areas that we've identified, and making sure that we look at the latest science available, we look at the caliber of that science, and we make sure that we review it as thoroughly as possible. And there's an expert panel, scientific committee that overlooks that process, and we're actually going through that process now. We will be publishing a series of abstracts in the next month or few weeks, which will contribute towards that science. We will be revisiting that process in March next year, and then come October 2022, when the next consensus meeting is scheduled and will hopefully take place, we will then publish the updated guidelines. So what is the current thinking? where are we with concussion assessment and management at the moment? Well, I think an important principle that I'd like to make sure I emphasize in this presentation is the concept of domains of concussion evaluation. We no longer just look at loss of consciousness and amnesia as the key aspects, but we look at a number of domains or areas of presentation, areas where the brain function could have been affected that are very important to take into consideration. And this is an excellent slide that I use repeatedly, put together by Dr. Paul McCrory, a neurologist and sports physician in Melbourne, Australia, who is one of the leads in our concussion process. And he's looked at and summarized a number of those key domains: neurological, cognitive, mood, behavior, autonomic dysfunction, sleep and hormonal changes, cervical presentations, and vestibular presentations. And on that inner circle, you see those represented. And on the broader circle outside of that, you can see how we evaluate those various domains. And then in the white area, how we might intervene in their management. So these are key areas, and various presentations might include one or a number of these domains, and each athlete, each susceptible patient, as represented on the slide, will be different. So very important to make sure you have the tools available to assess all of those. And those assessment tools involve the sports concussion assessment tools, now in their 5th version, which I think you will be familiar with. A thorough neurological examination, which is important, but as we've come to realize is quite blunt in terms of detecting the subtle changes of concussion. And then we have various cognitive tests, the verbal cognitive tests that are built into the SCAT tools, pencil and paper tests, computerized tests. All of these play a role. But as we've evolved through the various concussion consensus processes, we've come to realize that there's certain other critical areas which perhaps we haven't emphasized enough in the past. And 3 of those include the ocular or visual system, the vestibular system that regulates a lot to do with balance and orientation, and the proprioceptive system, critical in the sports person in terms of identifying the position of the body in space. And all of those 3 systems integrate to form a complete mental picture of where that athlete is. And they are absolutely integral in terms of sporting function, but daily function as well. So if one summarizes this latest thinking of the concussed brain, we appreciate that those are areas that we can assess, and they're areas that we can influence in terms of improving the presentation of that patient and their function, both with activities of daily living and on the sports field. So if we look at these areas that I've emphasized, and we look at, for instance, the afferent visual system, one sees that those tracts, those ocular tracts, go right from the anterior aspect, the front of the brain, where the eyes are situated, right through to the visual cortex at the back of the brain, covering huge areas of the brain. Similarly, the efferent visual system also is influenced by various areas and centers in the brain and covers huge tracts across the brain. Similarly, if we look at the vestibular system that is central to orientation, balance, and function, we see that further tracts spanning various areas of the brain right through to the brainstem are integral to the assessment and the manifestation of that athlete. And if we combine those into how they will interact and eventually affect musculoskeletal function, critical in an athlete, we see the various areas that are involved in the brain, the spinal tract, and the muscles. And so the challenge to us is to be able to evaluate those, but perhaps even more, to be able to influence them to try and get the athlete back to optimal function. And if we utilize those oculomotor and vestibular tracts and we're able to influence them, we're going to be able to have a significant impact on the athlete's recovery. And if I had to emphasize one area of concussion management that's changed in the last 5 or 6 years, it's the ability to influence and treat concussion. Concussion management is no longer passive. Concussion is a treatable disease, and our ability to influence balance, proprioception, vestibular, and ocular function is critical in terms of allowing that athlete to return to optimal function. And we're now able, through those interventions, to influence vast areas of the brain because of the number of tracts that these significant areas of function involve. So the essential tools to be able to do that are the following. One needs to be very familiar with the suite of sports concussion assessment tools. And those are in the process of being upgraded to the SCAT-6, but for the moment, these are the tools that one needs to be familiar with. To be able to treat concussion, as we've mentioned, the significant intervention, we need to be aware of how to identify those areas of brain function which have been affected. And then we utilize specific tools to be able to intervene. And one of the other significant changes is the intervention of exercise. We no longer hold athletes back because they have mild to moderate symptoms. We now use exercise, in particular supervised graded exercise, as described here by John Leddy, to actually improve the function of athletes. And this has been shown to be not only harmful, but beneficial as well. So sub-threshold exercise training has become a significant intervention. And as clinicians, you should be utilizing this tool in a stepwise fashion to improve the outcome in your athletes, because it's been shown that exercise times can improve, symptoms improve with the intervention of exercise, and that this is not harmful to the athlete, to their symptoms, or to the other critical measurements of health. To allow you to facilitate this multi-domain intervention, you need a multidisciplinary team. If you're going to be able to intervene and apply optimal concussion care, you need, as is represented here, a number of specialists in your field or in your domains to be able to allow that athlete the best access to care. And so you, as the sports concussion specialist or clinic manager, will be in the center of that, but you should have around you a network that allows you to afford the athlete access to the best available care. And that extends beyond medical professionals through to the athlete's personal concussion team. So that's the sports team involving coaches, athletic trainers, etc., and also the other doctors in the athlete's team, as well as the athlete's family. And if they're young athletes, particularly in a studying environment at school or at university, it involves their academic team as well. So this is very important to be able to utilize a range of skills, but also the support systems that that athlete relies on. One of the challenges we have is that the science of concussion has evolved a bit slowly, whereas the media attention and the demand for cultural change has really been exponential. And so it's very, very important to appreciate that we might not be advancing as quickly as possible, but certainly the number of excellent publications in the last decade has increased significantly, so that our science is now a lot more robust than it was in the past. So if we look at those key messages and we look at how they're going to be moved forward, unfortunately not in Paris 2020 and not in Paris 2021, but in Amsterdam 2022, which is where the next meeting is going to be held, we're really looking at these as key take-home messages. And I would, if there's going to be one slide that you that you take home with you from this presentation, it's that these are the key take-home messages for me. The first is to have a continued awareness of the broad range of concussion presentations. The next is to familiarize yourself with those SCAT tools and make sure they are an integral part of your field side management and form the basis of your office management moving forward. The next point is that you put a multidisciplinary team around you that's able to look at all those domains and help you with those more difficult and specialized assessments, and that you include in that team the athlete support team. And then importantly, that you look at those areas where you can intervene in concussion, acknowledging that it is a treatable condition, that you utilize subthreshold graded exercise that doesn't worsen the patient's symptoms, that you look at improving balance from almost day one, that you evaluate the vestibular system and the ocular system. And the best tools available for that are the vestibular ocular motor tests or VOMS tests, which are freely available, and that you look at functional interventions that will allow that athlete to reattain her or his optimal function in their particular sport. So we're looking forward to completing this systematic review process and to coming up with those new tools next year. And we look forward to reporting back on that. So I thank you for your attendance and really look forward to the questions that are to follow, and also to engaging with you in the concussion consensus process moving forward. Thank you very much.
Thank you very much, John, for the great summary, presenting the current state of concussion care and also a nice future glimpse into what's to come. So to me, the key take-home messages are that concussion remains an evolving science and we still have a lot to learn. It requires a broad interdisciplinary team, including the coaching team and also the educational team and broader. It is now clear that concussion has become a treatable condition. You don't just wait for it to go away. And importantly, so early symptom, sub-symptom exercise is conducive to earlier recovery. This is an important thing to know. So we are eagerly awaiting the next consensus statement. Thank you so much, John. So now I'm going to go straight into the next presentation, and I want to introduce our next speaker, which is Dr. Leigh Gordon. And as John has alluded to, Leigh is a sports physician. She comes from a family physician background in the United Kingdom. She is the team physician for the South African national sevens rugby teams. She's also an honorary lecturer in sports medicine at the University of Cape Town in South Africa. Internationally and nationally, she makes a contribution by being the course director of the World Rugby's Immediate Care in Rugby course in South Africa. And also she's been involved in event medical care at the Tokyo 2020 Summer Olympics in sevens rugby, but also in field hockey. So Dr. Gordon will present the excellent example which World Rugby has set in concussion care, and we look forward to find out how it should be done. Thank you, Leigh.
Good evening, everybody. Thank you, John, for that great introduction and overview of concussion protocols. And to Louis and John, thank you so much for the invitation to join you this evening on this Aspetar Online Concussion Forum. I'm privileged to be here, and it's great to be part of it, so thanks very much. I'm going to be chatting to you all about World Rugby as a federation, what we've done to reduce concussion, and what our protocols are from a community and a school perspective, as well as from an elite rugby perspective. There have been a lot of conversations about the safety of rugby union, and World Rugby as a federation has put a lot of effort and research into conversations with all the key stakeholders and looking at the positives and the benefits of playing rugby. And this slide really encapsulates all the reasons why rugby is a great choice of sport. I'll give you a sec to read through it. I'll be discussing World Rugby's approach to concussion protocols, both from a community perspective as well as an elite perspective. Our management protocols are very clear. For school and community games, there's a recognize and remove protocol in place. And for elite and professional games, we have the HIA, which is the Head Injury Assessment Protocol. I'm going to be chatting to you a little bit about the education that we do about concussion and who we involve in that education, both players, coaches, the medics, the referees, and the parents. I'll chat a little bit about the research we've done into the incidence of concussion at different levels of the game, how we assess concussion, manage it, and the use of the HRA protocol. Also be mentioning how player welfare has really influenced the laws of the game and how the Federation has changed the laws of the game to allow for assessment of concussion, really to reduce the incidence of concussion and to make the game safer. And in doing so, we've had interaction with all the role players, parents, players, and those players are both current and past players, the referees, as well as the coaches. World Rugby has ascertained that education is the main pathway through which we can increase the focus on concussion and reduce the incidence. So the education is aimed towards both the medics that are pitch side, as well as the coaches and the referees and the players. So in terms of medical education, World Rugby has an online platform, training platform called the Training Passport. There's one for medics as well as one for coaching. The Medical Passport has several online training modules, and there are 3 courses which consist of both an online aspect as well as a face-to-face aspect. So the online modules are concussion for general public, one for doctors and medical professionals, and one's for concussion for doctors and medical professionals in elite competition. The actual courses are the FAIR course, which is a first aid in rugby, and anyone can do this, whether you're medically trained or not. Then there's the ICIR, the immediate care in rugby course, and that is aimed at the doctors and physiotherapists who are pitch side for rugby union matches, and certain competitions have mandated that a level 2 ISOMedic is present for those competitions. So that would be, for example, World Cup, Junior World Cup, test matches, and so on. And then you have advanced ISO, which is only mandated for certain competitions. Pro 14 had it at one stage. And as I said, these are online as well as face-to-face courses, and you have to repeat them every couple of years to make sure that your accreditation stays valid. In terms of educating the coaches and the referees, I've mentioned that the online platform has got educational modules for coaches and referees, and then each country has local education platforms. South Africa has something called BoxSmart, which all coaches and referees at whatever level of rugby in the country have to undergo an educational day. It's at least 8 hours of education, and at the end of it you get a little BoxSmart card. And if anybody wants to coach rugby, even from the grade 1s and 2s, the littlies, or referee, they have to provide their BoxSmart card to show that they have gone through that education. World Rugby's done a lot of research into concussion. And currently, the ongoing studies, there's one between World Rugby, New Zealand Rugby, and the University of Otago, and to prevent biometrics. And they are undertaking a groundbreaking community rugby head impact study, which is looking at the frequency of head impacts in men's and women's rugby at both community and age grade rugby. Then we're looking at the latest eye tracking technology, which we're using to help with the identification and management of concussion. And that is now being integrated into the HRA protocol, which we use in elite rugby. The HRA protocol, which I'll discuss in a little bit, has been developed using a researched and evidence-based approach, But it's a dynamic and evolving protocol, hence our integration now of the eye tracking technology. So now if we look at the approach at different levels and we look at concussion in the community game and at school level, there is a clear mandated approach of recognize and remove. We are trying to educate everyone involved in the game to recognize the signs and symptoms of concussion, and that player needs to be removed and may not return to play on the same day. Hopefully everyone should recognize this. It's the Concussion Recognition Tool 5. It was brought out at the same time as the SCAT 5, and it's a little card that you can carry in your pocket to help you remember the signs and symptoms of concussion, and really little crib sheet. The latest introduction into the game is something called the blue card. And the blue card is a visual cue to everyone that's watching that a player has been identified by a referee, or any of the medical staff for that matter, that they are concussed, or that there's a strong suspicion of concussion, and that they need to be removed and managed appropriately. And many countries have introduced this into the community game to improve the assessment and management and the safety of the game. So now if we look at the elite level game, we use the HIH Protocol, Head Injury Assessment Protocol, and it's a 3-stage process that we have introduced for elite adult teams to assist with the identification, the diagnosis, and the management of head impact events, which have the potential for concussion. So the protocol consists of the following 3 stages. There's the stage 1, which is the game day assessment using an HIA Form 1. Then stage 2 is post-game on the same day. So usually within 90 minutes of completion of the game, we do an HIA Form 2. And then stage 3 is HIA Form 3, done 36 to 48 hours after the injury. So that's usually after the players have had 2 sleeps. So in order for the HRA protocol to work, we have, in addition to our matchday doctor, we have an HRA doctor or concussion spotters who are watching via video technology, and we have the videos are set up so that there are at least 6 different angles of the game, and they look at either events where there are clear signs of concussion. We have 11 level 1 criteria which require immediate removal from the field, and then they are also looking at events with the potential for concussion. So in order to facilitate this, the laws of the game have changed, and World Rugby have actually changed the laws in order to allow for a 12-minute pitch side assessment. The player can come off, they can be assessed, and if they pass their assessment, they can go back on, which doesn't affect your substitution rulings. So that makes a very big change in terms of how the game is played and the safety. But on the converse side, we've also looked at changing the laws of the game for sanctioning, so that if there is head contact or contact above the neck, they are looking at changing the laws and regulations around the sanctions for that. And these laws are aimed at and designed to protect the head, the neck, and the throat of players. And it can be, there's something called the head contact process, and it helps the referees look at high tackles, shoulder charges, dangerous cleanouts, head-to-head collisions, and where players are leading with the elbow or the forearm. So if we look at the HRA protocol in a little bit more detail, in stage 1, if there is a player who has sustained a head impact event with the potential for concussion, they can be identified by any of the match officials. So that's either the referee or a team doctor or an independent matchday doctor. And that can be observed either directly or on video review. And I should say here that we've instituted a protocol whereby your independent matchday doctor has the final say. So they can overrule a team doctor, because in the event, obviously, if a key player has a suspicious tackle, it may be that your matchday doctor might be slightly more objective than a team doctor. So And you also don't want a situation where team doctors from one side are asking for an assessment on a player on the other side for reasons that may not be entirely medical in nature. So the HRA1 has 4 components. First one is the level 1 criteria that I talked about. Those are clear signs of concussion and the player needs to be removed. The other 3 components are an off-field screening tool. So these are for if there's a potential for concussion. So there's the off-field screening tool with pitch side video as well as a clinical evaluation by the doctor. So to be clear, if a player has any of these level 1 criteria, signs or symptoms, confirmed loss of consciousness, suspected loss of consciousness, convulsions, tonic posturing, you can read through the rest of those there, they must be immediately and permanently removed. If you have criteria 2 signs and symptoms, so here where you've had a head impact with a potential of a head injury and where the diagnosis is not immediately apparent, then that player is removed. They are and then further assessed. So the HRA1 is a multimodal tool, assessment tool, where you have a suspected concussion and any of those criteria 2 signs and symptoms have been identified. So as part of our HRA protocol, we have baselines for all players. At the beginning of each season, the team doctor does their concussion baselines, and usually, so that includes a baseline STAT-5, as well as a baseline neurocognitive test, computerized neurocognitive test. And we are now starting to introduce baseline visuo-oculomotor testing to your eye tracking technology. What you see on the right there is a nice eye tracking. The technology looks like little binocs. You look through the binoc and you see a little red spot that moves round and round, and your eyes track it, and you should get a lovely circle following that line. In concussed patients, it doesn't look anywhere near that. And we know that baselines improve the accuracy of the HRA1 on game day. So the baseline SCAT is put onto an app called CSX, and this app is then available for all matchday doctors on the day, and they can compare the player's SCAT-5 to their baseline function. So the big question about the HIH protocol is it effective? Does it work? And the answer is a resounding yes. It is 92% successful in identifying concussions. And before the whole program was instituted, before 2012, our evidence showed that 57% of concussed players returned to the field on the same day, which is obviously a huge problem since concepts of second impact syndrome. If you have a concussed player, they're much more vulnerable to further concussions, and obviously the concept of a second impact where that second impact can be fatal. It's really, really important for players to be identified so that they aren't returned to play on the same day. So following the introduction of the HIH protocol, we have now shown that only 11% of concussed players are returned to play on the day. And really this is showing that it's as sensitive as a shoulder MRI. So we're doing really well. We're not there yet. And the World Rugby Research Unit is constantly looking at all factors in helping identify concussion in order so that we can reduce that final 10 to 11% so that they don't go back on field. So the HRA is a dynamic and evolving process. So Rugby Union has a clear graded return to play protocol before players can be returned, and those include mandatory rest periods, which is dependent on the player's age. So players who are 18 and younger have a minimum 2-week relative rest period, even if they're elite players. So the earliest they can return to rugby to matches is on day 19. For players who are 19 and older, they have a minimum 1-week relative rest period. So their earliest return is on day 12. So this is in the community and at the school level. And I suppose it's also important to note here that if we have an 18-year-old who's playing in elite rugby, they fall under, because of the age categorization, they fall under a recognize and remove. They don't go into the HRA protocol, so they follow the recognize and remove, and age banding is actually more important for their return to play. At the elite level requires that there's an advanced level of concussion care available, and you need at least doctors who understand and have training and experience in recognizing and managing concussion. You need access to brain imaging facilities and specialists who can interpret that imaging. And then you need a multidisciplinary team, which includes neurologists, neurosurgeons, neuropsychologists, neurocognitive testing, and balance and vestibular rehab specialists. So this team makes it possible for players to potentially be returned to play earlier than that relative week, but there needs to be a lot of consideration put into that, and we've now instituted a pathway by which, if elite players want to return earlier than the week, they need to consult with an independent concussion specialist like John. So currently, 2/3 of our concussed players do not play the following week, and many don't actually return within 3 weeks. So when you're watching your players carefully, it does have a significant impact on their return to play. So looking at the graded return to play, I'm sure most of you know this, it's 24 hours per stage, and everybody must pass through it. And that stage 1 to 2A is determined by their age. As I said in the previous slide, that if you're 18 and under, it's at least 2 weeks. It used to be complete rest, but now it's referred to as subsymptomatic activity. So can jog, light activity, as long as it's not eliciting any symptoms. So that brings me to the end of my talk this evening. It was a whistle-stop tour of concussion management protocols in rugby union. World Rugby is really focused on player welfare and putting the safety of players first. So a lot of time, effort and money has gone into the research behind these protocols. And it's a constant dynamic process that we are trying to make the game safer at all times. Thank you for your time.
Thank you so much, Leigh. It was a joy to listen to this really sophisticated concussion care program that has become normal practice in rugby over a large part of the game. What struck me is the extensive education across the spectrum of people involved, including referees and coaches and so on, that makes it work so everybody's on the same page. I like the novel recognition tools, especially the blue card system, and obviously the head injury assessment at the elite level. Also, the novel assessment tools such as video reviews that's available at field side and independent spotters. Of course, this is important to know that all of this is driven by policy at the highest level. So from World Rugby level and also backed up by high-end research. Thank you so much, Leigh, for that. Now, I want to introduce our next speaker, my colleague at Aspetar, Dr. Raouf Rekik. Raouf is a sports physician in the National Sports Medicine Program. He is the club doctor and medical clinic director of Al-Khatiriyat, a football club and sports club. But more importantly, he's the head of the National Sports Medicine Program Scientific Committee, also a member of the Aspetar Hospital Scientific Committee, and he is the coordinator of the education group in the National Sports Medicine Program, so a real key role player. Raouf has extensive experience as a sports physician at national level in Tunisia. He has covered many international events as event medical officer, including international handball competitions, athletics, and so on. Raouf is a key member of our Aspetar Sports concussion team. He's really a critical link between our concussion program and the team doctors, especially in the Qatar Stars League. So to present his real life experience in implementing good concussion care in his club and in the National Sports Medicine Program, thank you very much, Raouf. I hand over to you.
Thank you. Thank you, Luis, for this nice presentation. So good evening, everyone, or good morning or good afternoon, depending on your time zone in the world. Masā al-Khair for the Arabic-speaking attendees. Today, my presentation is entitled Implementing Best Practice Concussion Care in the Qatar Stars League, Real-Life Challenges and Successes. I have no conflict of interest to disclose in regards to this presentation. And here are the learning objectives of my presentation today. As long as we played football since so many decades, concussion always existed or occurred. It is a brain injury resulting in a disturbance of the brain function. And in direct contact injuries, the head can hit another head, a ball, or the ground. However, football-related concussion has been broadly discussed only following high-profile cases at the 2014 FIFA World Cup in Brazil, particularly the incident which involved the German player Christopher Kramer during the final match when he slammed his head into the shoulder of the Argentina Ezequiel Garay. Following that, FIFA Medical Commission implemented changes to the concussion protocol during games, but was it sufficient? Did it resolve the problem of football-related concussion management? Unfortunately, the main medical issue at the World Cup 2018 in Russia thus far has, not surprisingly, due to the media coverage, been the management of concussion. This recent paper that assessed head collision and their frequency during the 2018 World Cup concluded that concussion assessment protocols and their implementation by large sporting governing bodies may have widespread effects on officiating, coaching, and play of athletes around the world. Concussion assessment and management in international football continues to have significant room for improvement. This paper did review the relevance of sport-related concussion for football. It concluded that soccer or football fulfills the criteria of a contact sport and is characterized by a high incidence of concussion. Even, in recent papers, it demonstrates that adherence to the recommendation for the diagnosis and management of concussion by players, coaches, clubs, and officials is still insufficient. In this slide, I will read what wrote Jeff Cullant in the blog of British Journal of Sport Medicine under the title Concussion Management and Mismanagement at FIFA World Cup 2018. He said, "We need to ensure that all medical teams working in professional football and all sports for that matter are using evidence-based medicine and are aware of the significance of concussion. And with its recognition and subsequent management, only then will we ensure player welfare is taken seriously." Important to emphasize that the 2016 consensus statement on concussion in sport during the conference on concussion held in Berlin stated that concussion in sport is among the most complex injuries in sport medicine to diagnose, assess, and manage. Is it true? Unfortunately, yes. In fact, so many players have had their careers cut short. You can read here some names and you can find much more in international media. So what's the situation for Qatari football players? In this slide, you see the injury incidence in 2012-2013 football season, about 9 years ago, with the distribution of injuries according to location and for concussion, of course. There was 6 cases, so 2% of overall injuries. Please remember this percentage, you will see it later. A few years later, I calculated the number of cases of concussion for 4 years of data collection between season 2013-14 and season 16-17, and found an average of about at least 2 cases of concussion by season in QSL, in Qatar Star League. Recently, and exactly last season, Head injuries, mainly concussions, represented about, again, 2% of the overall injury incidence. Our colleagues from Asprev group in Aspetar are working to give us soon some more relevant and detailed results on concussion epidemiology for last 7 seasons in Qatar. And a new project is coming soon. I will not speak about it right now, as it's not the purpose of this presentation. Now I present you 3 cases of head trauma. And as watching this video from Al-Kes public television, please try to guess if it's a concussion or no. Watch if there is any tonic posturing, any possible ataxia. You will see now the replay of the head trauma between these 2 players. We see that both got injured. As we watch, the player in white t-shirt seems to have a more serious injury. Look now to the player in white t-shirt, how he falls. We guess he had loss of consciousness. And the player in green was not replaced. He tried to continue to play, but look to his blank look. He tried, but finally he was not able to continue and he was replaced. Now, second case, it's a goalkeeper, a football player, 17 years old, with a remarkable medical history. So this player had his first training with first team because the first team goalkeeper was injured and they needed him to support the first team. He was happy about that, but he was not ready in his fitness and also mentally. He had a head trauma, and the evaluation on field concluded with the SCAT-5. The medical doctor concluded to a concussion. Ambulance called. He was taken to hospital. He had a CT scan normal, and he was referred then to Aspetar Concussion Clinic. He was advised 1 week of cognitive rest. However, when he improved after 24 hours, the coach and the player agreed for an early return to play because the coach needs this goalkeeper and the player is happy to play in first team. It's an opportunity for him and he doesn't want to lose it. Hopefully, the club doctor, with the help of the father of this 17-year-old player, understood the gravity of the situation, and their input, especially the father, guaranteed that the player will take his 7 days of rest and will return progressively to play. The third case is to say that not any concussion is just a concussion. Here is a football player who played a match. He has a face trauma, concussion as a diagnosis, taken to hospital. X-rays anterior of the skull showed indirect signs of hydroauric levels, but it was not so evident. Then the CT scan showed a fracture of the anterior and lateral walls of the right maxillary sinus with hemosinus and fracture of the lateral wall of the right orbit, both cerebral hemispheres being normal. Following these 3 cases and what I said, we understand from all this that concussions cause a significant healthcare burden and affect the long-term health of many football players worldwide. A poor care of a concussed player could lead to the aggravation of his concussion, a longer recovery time, an increasing risk of other injuries, and even death. That's why, as a club doctor, medical staff, and in particular, a team, not only the doctors, but also the physiotherapists and all the staff dealing with the player on the medical side, you have to prepare yourself for such events through the implementation of a concussion program in your football team. Otherwise, if you fail to prepare to fail. If self-distancing is a good solution to avoid concussion in these times of COVID-19, Of course, it's not possible in football. So we understand then that the solution is a concussion program that aims to assist club doctors and physios, coaches, and football players to improve their understanding of concussion in football and make better decisions when caring for football players or other athletes in general. Through the last years, Aspetar supported club medical staff and empowered healthcare providers involved in the medical care of football players in Qatar to recognize, remove from play, assess, and do initial monitoring and appropriate referral of athletes or football players with head injuries, according to the best evidence and the best practice in an integrated sport concussion management program. Aspetar concussion team organized workshops, lectures for club medical staff, as well as information sheets for coaches and managers, information leaflets for football players, and organized as well social media campaign. The concussion team in Aspetar invited the club and federation doctors in February 2018 to make use of the Aspetar concussion clinical pathway in the aim of an early, safe return to play and prevention of such of further injuries. It includes the management flow chart of suspected concussion. I will leave Luis, my colleague, to discuss furthermore about this amazing team in Aspetar of experts. A concussion program includes awareness and education, baseline testing, concussion management, and graded return to play protocols based on the best available evidence available in Aspetar Sport Concussion Program that you see on the right. To implement successfully such concussion programs, you need to reach an agreement with all stakeholders in regard to the concussion management and return to play of your concussed players. And here, you're not a doctor in an hospital. You are in a setting that belongs more to the other parties, to the coach, to the players. And here there is, I summarized the challenges in three. The first challenge, as a club doctor, the first one is yourself. In fact, based on injury incidents, do you reconsider concussion as a priority? What about your knowledge on the topic? What about your skills, including communication skills? Finally, how you take decision in such not easy situation. Second challenge is related to the coach. Some coaches consider a player as a warrior who should overcome pain, contusions, and even a concussion. The Moroccan manager Hervé Renard, during last World Cup 2018, described his player as a warrior as he played few days after having the concussion in the first match. Furthermore, the main nightmare of a medical staff or a doctor is when they change the technical staff and the coach in the middle of the season. Then you have no choice than starting again the whole process. Players represent the third challenge, and it depends on their psychological profile, their fear to lose position in the playing 11. You remember my case of the 17-year-old player that I presented, their stress or fervor during game, and the importance of the match. The education here is very important, and you need to improve the athlete awareness of the signs of concussion, potential risk of unreported injury, and potential long-term consequences. The gap between both parties should disappear through communications, understanding, and shared decision-making. Thus, education is a key element and should target all stakeholders through collaboration, respect, and trust. We need to apply a multidisciplinary team approach to head injuries management in sport. FIFA Medical Committee stressed that an education program for team doctor, coaches, referees, officials, and players should be undertaken, which is a support to the doctors in order to introduce the education program to their clubs. Where some coaches could be reluctant, some could say, if you make this education and you take the responsibility of the decision of stopping my player from resuming a game, I might lose this player. I might lose the game. Such reluctant coaches could be influenced by the FIFA recommendations. If you look to an example of the Heads Up program for high school players, developed by the CDC, the Centers for Disease Control and Prevention, education provided to parents, high school coaches, and physicians has improved knowledge of concussion signs and symptoms and improved prevention and management practices. The objective of the education is to have informed healthcare professionals, informed players, informed coaches, and officials. Thanks to knowledge transfer, practice fair play and good sportsmanship for players should always be reminded. To prevent any misunderstanding between stakeholders and based on the 3-talk model, I borrowed this slide from Louis. Shared decision-making is usually done between a doctor of a player or a player. We will transposing this. Originally, it's between a doctor and the patient, but I transpose it to the field of play, to the football. So it consists of assembling a team of decision makers, such as the player, the coach, the manager, etc., with the doctor. The problem is presented to the team, and all possible ways to manage the problem are discussed. This involves education on the topic, followed by discussing possible consequences according to the patient's assessment until a shared decision is reached, and everybody agrees to the process. But this needs to be done in advance. And here I come with this nice paper from my colleague and friend Louis. I suggest you to read it. It's in British Journal of Sport Medicine. The title is Shared Decision Making in Sport Concussion, Rise to the Occasion to Take the Heat Out of the On-Field Decision Making. I think Aspetar Sport Concussion Program, material, protocols, and team of experts brought better awareness of healthcare providers in clubs and led to better diagnosis and better reporting. That's why concussion incidents nearly did not increase in the last 10 years, because if there is better reporting, we should have an increase in these incidents. However, since the incidents did not increase, we should say that there is a positive impact of the implementation of best practice concussion care. However, there is still room for improvement, of course. We should make football safe for players' limbs, but also brain. The players and their coach need to understand that if they need their brain to be performant, to use their skills and take advantage of each opportunity, concussion will not allow them to do that. Now it's time for my take-home message. Concussion has many different symptoms and loss of consciousness is not always present. Concussion is not as visible as a hamstring injury, but must be taken seriously. If a hamstring injury probably won't lead to death, concussion do. Concussion affect performance as well, which is important for the player and the coach. And graduated return to play is always important for a football player following a concussion. Concussed players should accept team doctor decision to be removed from playing or training and must not return to activity until cleared by their doctor. This cannot be guaranteed without education leading to a shared decision and agreement done beforehand, in general, in the beginning of the season. To do so, you need to implement a concussion program, including the 4 steps I presented to you: the awareness and education, baseline testing, concussion management, and graded return to play protocols, based on the best available evidence available in Aspetar Sport Concussion Program. So please don't forget, if in doubt, get your player out. Thank you for your attention, and don't forget that if you fail to prepare, then prepare to fail. So what's your plan for concussion care? Thank you, everyone.
Thank you so much, Raouf, for giving us this real-life perspective and reminding us of the real-life complexities and also the challenges that you come across out there with the team. It's clear to me that preparation is key. Education is key, as everybody has said so far. And a good relationship of trust with your coach is essential. So thanks for all of this. It really gives a richness and a realness to our proceedings tonight. So now it's my privilege to introduce Dr. Carolyn Emery, who, as you can see, is a physiotherapist and an epidemiologist. Dr. Emery is a professor with tenure at the Faculty of Kinesiology at the University of Calgary in Canada. She holds various public appointments and academic appointments. What we know is that one of the main focus areas of Dr. Emery's research is concussion prevention. She's a really preeminent researcher and physician and concussion leading thinker. So eminent is Dr. Emery that she was inducted as a Canadian Academy of Health Science Fellow, and she's a Royal Society of Canada News Scholar, really important positions to hold. So as John has said, Carolyn's work in the prevention of concussion is world famous. So it is really my privilege to introduce Dr. Carolyn Emery to speak about her research in prevention of concussion.
Hi there. It's my great pleasure to present at the Aspetar online forum focused on concussion. I've been asked to present today on the prevention of concussions, and the focus of my talk will be in youth sport. I call my research program SHRED Concussions, which stands for Surveillance in High School and Community Sport to Reduce Concussions and Their Consequences in Youth. I'm presenting today on behalf of the Sport Injury Prevention Research Centre at the University of Calgary in Alberta, Canada. I'm also presenting on behalf of a large team of researchers, including graduate students, as well as postdoctoral scholars. This work couldn't be done without our strong clinical and community sport partnerships, as well as multiple funding agencies. The public health burden of concussion in youth is significant and worldwide has an impact. We expect a 1 in 5 lifetime risk of concussion, and 50% of these occur in individuals under the age of 19. In youth, 60% of concussions are sport-related. And in Canada, we expect 1 in 10 youth will sustain a sport-related concussion each year. 30% of these are recurrent and 30% are symptomatic for months, providing significant opportunity for secondary prevention of consequences of concussion. When we looked at sport-related concussion in a large cross-sectional survey of Alberta high school students, close to 2,000 kids completed this survey, and 14 to 19-year-olds. We see a 28% lifetime prevalence in boys and a 14% prevalence in the past year. For girls, slightly lower, 22% lifetime prevalence and 10% prevalence in the past year. This is a significant public health concern. When I speak to prevention, it's across the continuum from primary prevention of concussions in healthy youth participating in sport, secondary prevention of recurrent concussion, and tertiary prevention or rehabilitation to reduce the consequences of concussions in youth. We can have a more significant impact if we move upstream in our approach to prevention. As clinicians, it's also important for us to educate and inform primary prevention strategies that can reduce concussions in larger populations of individuals. You're all probably familiar with the Van Mechelen model for sport injury prevention research. And specifically, I wanted to highlight that when we're evaluating prevention strategies for concussion in youth sport, the validation of the surveillance system is critical so that we can both evaluate risk factors, but also prevention strategies for concussion. In our surveillance strategy, we also have very strong partnerships with clinical partners in the community, where we have physicians and therapists following up on injuries as well as concussions, and with our community sport and school partners to facilitate as complete data as possible in all of our studies. Our injury surveillance includes components of consent to participate in research, collection of practice and game exposure data. So we have a denominator in our injury rate assessments and concussion rate assessments. We also have kids that follow up following a suspected concussion for diagnosis by a study physician, as well as therapist follow-up for all injury. Our injury and concussion surveillance efficiently feeds back to the clinician to inform return to play and return to learn, as well as our sports stakeholders to best inform practice and policy as it relates to concussion prevention and management in youth sport. Our targets for prevention cross rule changes, equipment, and training strategies. And I'm going to highlight some of our research related to these 3 targets for prevention of concussions in youth sport. Also highlighting our community partnerships so that make it possible to do this research, as well as to get that research back to our community partners efficiently to inform best practice and policy. So I'll start with rules and policy. And we've been evaluating policy related to body checking in youth ice hockey for over a decade. And one of our early studies, a cohort study, allowed us to evaluate injury and concussion rates in 2 provinces. In Alberta, in blue, where we had policy that allowed body checking at all levels of play in 11 and 12-year-olds, compared to Quebec, which disallowed body checking in 11 and 12-year-old ice hockey and delayed body checking in games until age 13. Body checking in ice hockey is like the tackle in rugby, removing the player from the puck intentionally and with significant force. What we found was a significantly higher rate of concussion, almost 4-fold greater risk of concussion in Alberta compared to Quebec at this time. Over time, with many public forums, working closely as well with our community partners provincially and nationally, we informed a policy change where Hockey Canada in 2013 disallowed body checking at all levels of play in 11 and 12-year-old ice hockey. This research informed a policy change which we were then able to evaluate. And highlighted in red, we see a significant reduction in concussion by over 64% and rates of concussion associated with time loss of more than 10 days of 44%. We translate this to the impact nationally. We estimate a reduction of over 4,800 concussions in this age group alone annually in Canada. We further were able to evaluate local and provincial policy change disallowing body checking in older adolescent age groups in non-elite levels of play. However, when we say non-elite levels of play, it's still 60 to 70% of players engaged in ice hockey in this age group. With these policy changes, we saw a 64% reduction in concussion in the 15 to 17-year-old age group in non-elite levels of play, and 59% reduction with more significant concussions leading to more than 10 days time loss. An estimated reduction of 1,760 concussions annually in the 15 to 17-year-old age group. Dr. Paul Lyson, during his PhD, he evaluated the unintended consequences of concussion. So in this work, he evaluated kids who were participating in body checking leagues that were 13 and 14 years old with varying number of years of body checking experience, 0, 1, or 2 or more. And what he shows is that there was no significant difference in concussion rates based on body checking experience, hence demonstrating no unintended consequences of delaying body checking to age 13. Further to this, over a 5-year cohort study and over 1,000 players, he evaluated body checking experience in the oldest age group, 15 to 17-year-old players. And what he found was actually a slightly higher rate of concussion injury in those individuals who had more body checking experience. Again, no evidence to support that delaying body checking to an older age group would have a greater risk of concussion or injury. Another policy is the zero tolerance for head contact, penalizing all intentional and unintentional player head contacts aimed to reduce concussions at all levels of play in ice hockey. When we first evaluated this policy change before and after the 2011 zero tolerance rule came into effect, what we found was actually higher rates of concussion in age groups 11 and 12, as well as 13 and 14-year-old players. This was likely unrelated to this zero tolerance policy change and more likely related to greater media attention and hence perhaps greater reporting of concussion. This rule change was not evidence informed, and it also raised questions about how much influence referees had in this policy change. We also did video analysis before and after the policy change and showed no differences in head contact rates, their direct head contacts, player to player, or secondary head contact to the ice or the boards. Further to that, the proportion of all head contacts in this video analysis that were penalized was around 13% before and after the head contact policy change, demonstrating that over 80% of these head contacts are in fact not penalized based on the rules. So head contact incidence rates and enforcement did not differ with policy implementation. When we look at equipment and equipment recommendations, in ice hockey, one of the seminal papers evaluating mouthguard use in a nested case control study demonstrates a 64% reduction in the odds of concussion with mouthguard use. This is comparing cases and controls, where cases are those that sustained a concussion and controls a non-concussion injury. Further to that, we evaluate helmet fit and we developed helmet fit criteria, which were then assessed for reliability. And in a preliminary cohort study, another nested case control study, we see a twofold increase odds of concussion when 2 or more missing criteria are found in the helmet fit criteria assessment. This is informing future work. And so around equipment, we're interested in mouthguards, mouthguard types, helmet and face mask types, as well as validating helmet fit assessment. And during the COVID pandemic, it was important to consider virtual, video supported helmet fit assessment, as well as in person. I want to highlight some work of Ash Golstad, a PhD student in our program, that evaluated mouthguards further to the previous study using 2 approaches: a prospective cohort analysis across 5 years of a cohort study and kids ages 11 to 17, and demonstrates a significant reduction in the rate of concussion in those who report wearing mouthguard during games, as well as for both off-the-shelf as well as dentist fit types of mouthguards. In a nested case control analysis, using the same data, he demonstrates a significant reduction in the odds of concussion, as well across both mouthguard types. There are, of course, strengths and weaknesses of both approaches, but important that these findings were consistent. This is not published, and I would ask you not to share this information through social media. Neuromuscular training strategies are well known in youth sport across exercises that include aerobic components, strength, agility, and balance training drills. We know across multiple randomized controlled trials that we see a 30 to 70% reduction in all injury as well as lower extremity injury rates with neuromuscular training warm-up strategies. We went back to one of our randomized controlled trials in youth soccer, and we also see some potential effect of this neuromuscular training in reducing concussion rates. This is not significant, as you can see, with the confidence intervals spanning 1. However, certainly informed a need for further evaluation in larger studies with a focus on concussion prevention. In addition, in schoolboy rugby, our colleagues at the University of Bath demonstrate a 59% reduction in concussion rates when neuromuscular training is completed at least 3 times a week. And this particular program also included some neck strengthening exercises. And we see here a significant reduction in concussion. So we have been scaling up our neuromuscular training strategies broadly across multiple sports. And a shout out to Carla Vandenberg, who is our knowledge broker, who has delivered more than 100 workshops to more than 2,000 teachers, coaches, and other participants, so that they can deliver neuromuscular training within the context of their team in training and practices. We've increased the components related to sensory motor training in these programs, and we're currently evaluating those across multiple sports. Wanted to highlight high school rugby in Canada. And Isla Schill is a PhD student in our program, and she's got a focus on the prevention of concussions and injuries in the female youth game. But I want to highlight in this cohort study that across boys and girls, we see high rates of concussion. 23.5 concussions per 1,000 match hours for boys, and even higher for girls at 37.5. And to put that into context, this is higher than we even see in professional rugby union. And this is a significant concern in Canada currently. And it's important to note that a lot of kids going to high school in grade 10 that are 14 years old, particularly girls, have not been exposed to collision sport previously. And so there's a lot of work to be done in this area. And I want to highlight a multifaceted approach to prevention. And again, Isla Schill, PhD student, and Dr. Stephen West, who we recruited from the University of Bath following his PhD, who's a postdoctoral scholar in our program focused on rugby injury and concussion prevention. They are using video analysis to be able to evaluate rule changes and the impact on match events, tackle characteristics, and head impacts. And further to that, using video analysis going forward to establish and improve practices in the coach delivery of safe and effective tackle training. Neuromuscular training warm-up strategies are being evaluated, and we developed our program in partnership with the University of Bath, England Rugby, and World Rugby. And of course, also considering equipment, mouth guards and headgear, although very few kids in Canada are wearing headgear, so it will be difficult to evaluate that. But we will look at mouthguard types, certainly, in this population. We're also using mouthguard accelerometry to better understand head impacts in the sport. Our SHRED Concussions Research Program is a pan-Canadian program actually funded through the National Football League Play Smart, Play Safe program, with a focus on concussion prevention, detection, diagnosis, prognosis, and management in youth. We're recruiting over 6,000 kids in 12 high-risk concussion sports, and we will follow them over 3 years. We are in year 2 of this study, and we expected this study to yield over 600 concussions a year. To date, through the pandemic, of course, we have seen fewer concussions. However, they're certainly ramping up now as kids are back to playing sport, and particularly collision sport. We have a SHRED surveillance portal, which is accessible to all of our study personnel, as well as to the kids participating in our study. And our aims are to establish concussion surveillance nationally so that we can evaluate prevention strategies across multiple targets, so that we can better understand models to validate detection of concussion as well as to predict recovery in youth. And this will provide a platform for the recruitment of kids to our randomized controlled trials to evaluate treatment strategies aimed to prevent long-term consequences in youth. Hot off the press, this is our SHRED mobile. It's just arrived in town and long awaited. And we are going to take our research program as well as our workshops and education programs out to the community, to rural communities and Indigenous communities, to expand the impact of our work. So this is very exciting news. So overarchingly, we do need to move upstream towards primary and secondary prevention to have the greatest public health impact. This is an important component of the work that we do as clinicians as well, thinking about primary prevention in every context. We want to scale up validated injury and concussion surveillance so we can evaluate concussion prevention strategies across multiple targets for prevention. We aim to reduce concussions 25% by 2025 in our communities. I want to thank you very much to again highlight our funders and our team, and as well.
Thank you very much, Caroline. Thanks for sharing your exemplary concussion research program. You've shown us that enforcement of policy is effective in prevention, rule changes are effective, and showed us that body checking is really effective in especially ice hockey. And what's absolutely interesting to me, as you've shown eloquently, that body checking rules and preventing body checking in young age does not affect player skill development later on. You've also showed us that protective gear is preventative, conditioning is preventative in a variety of sports, including neuromuscular training, cervical strengthening, and tackle training. So thank you very much for this very eloquent presentation, Professor Emery. John, now I hand back to you.
Thank you very much, Louis. I echo your words about Carolyn's presentation and the quality of it. It's now a great pleasure to introduce my co-host, Dr. Louis Holtzhausen, who is the Deputy Chief of Sports Medicine at Aspetar Orthopedic and Sports Medicine. Louis has travelled a long road in the sport and exercise medicine world. He's one of our senior colleagues, and it's been a great pleasure to work with him and to see him rise in his new environment and, very importantly, make an impact as the director of the Aspetar Sports Concussion Program. So, Louis, we look forward to your presentation on the work that you've done with your team in establishing a sports concussion program at Aspetar. Over to you.
Thank you. Thank you very much, John, for the kind introduction. Yes, we certainly go back a long way, John. So we at Aspetar have developed a sport-related concussion program to serve the National Sports Medicine Program here in Qatar, which takes medical care of all registered athletes in the country, from schools level to professional level. And I'm proud to share some details of this thing with you, especially at this time when the Qatar Stars League, which is the professional football or soccer league in the country, has recently adopted our sport concussion terms of reference as policy. And we are in the process of implementing this concussion program in the Qatar Stars League. So this is really a proud moment for us because this is unprecedented, certainly in the Middle East. I have no conflict of interest. I will outline the components of our program to you, and I will show you a way forward in planning a sport-related concussion program in your club or federation. And I want to introduce you to the IPARAS framework, which is an implementational science framework for implementation of health systems, which is a really helpful tool in developing things like sport concussion programs. The Aspetar Sport Concussion Program consists of 5 distinct parts, which I present to you in relation to the progression of treatment of concussion.
where we start at the pre-injury or preparation stage, then move to the immediate post-injury or on-field stage and at the right of your screen there. Then the management in the first 24 to 48 hours at the bottom, and further management of concussion up to return to play. And we conclude with a golden link between all these components, that of continuous review and innovation. So the baseline preparation is the foundation on which this program is built. It all starts with increasing and raising awareness and education amongst all stakeholders in sport about this condition, which is traditionally totally unlike other injuries that we encounter and so easy to be dismissed. Secondly, in the preparation, concussion requires a multi-professional team of healthcare practitioners, but also administrators. And the second step in the preparation is therefore to build a referral and a management network. And lastly, in the preparation phase is to facilitate baseline testing in your chosen athletic population, in this case in the registered athletes in Qatar, but specifically the Qatar Stars League. The second domain of our program includes facilitation of recognition of concussion and correct immediate clinical care, which relies heavily on education, again, and availability of assessment tools there at field side. We have developed a referral network and a decision-making flowchart to guide the first 24 hours of concussion care. And then we also have developed customized clinical guidelines and have a multi-professional clinical team available to manage concussions, including sports physicians, physiotherapists, neuropsychologists, and very specifically an educational expert, with also a referral network for neurosurgery and for neuroimaging. The little blue box there at the end is the glue which binds this whole program together. Where we monitor our progress, and from that we do innovative thinking and research in the quest for improvement of our system. Now, a program such as this is just as effective or good as how well it is implemented and received in a sports environment. And historically, concussion plans have been rather unpopular and the adoption slow and challenging for various reasons that have been mentioned here before. So to make it work, one has to be rather innovative, and it's been helpful to us to use principles of implementational science to guide us. And we used a hybrid of different models loosely based on the IPARIS framework for implementation of healthcare systems. Now, this framework makes use of a formula that you can see there in front of you. It looks rather complicated, where SI in the beginning there stands for successful implementation, and successful implementation is defined by achievement of the previously agreed project goals, that this new plan becomes normal practice, such has been happening and shown in rugby, that there's inclusive membership or ownership of this, and there's minimal variation across the users of this new healthcare system. Now, FACN just stands for facilitation, so you need to make the magic there between three factors, I plus R plus C, where C stands for the context, inner and outer context, so the socio-cultural environment, the geographical environment, and so on. The R stands for recipients, the individuals, and the collective, the culture in the sport and in the country or in the environment that you're working with. You need to understand
how people are best engaged in new systems. And obviously the I then stands for innovation. So that's again making magic. So this complex formula just tells you to use your common sense really. So for us, we listened to them and we started by understanding the setting, the context here in Qatar, the culture, and of course our capacity to deliver this type of work. And then we went forward to translate what is already known into formats that can be digested by our local population. And only then could we start thinking of operationalization of our concussion program. So I want to demonstrate how we went around this context and understanding the context by explaining the 4 factors that Caroline Finch has identified in 2011 already. So as far as interpersonal factors are concerned, we operate in a very multicultural society where people are from various different backgrounds. Our sports teams come from all over the world, and with people with different perceptions, different ways of life, different ways of thinking, not even to mention the problems with communication and language. Socio-culturally, this multicultural society is embedded in a traditional, even though progressive Arabic culture, with typical hierarchies, high context thinking and decision making, quite different to what I am used to, for instance, which has to be embraced if you want any chance of success. And of course, it is important to understand the messenger, in this case myself, and the systems understanding and perception of me and my way of thinking. And then one needs to understand how to build the bridge into trustful relationships to make implementation work and to be heard at all. Of course, policies are all important, as we've seen in the previous presentations. They are key to concussion care and have been sadly lacking until pretty recently in soccer football. But then again, in the absence of a policy in a sport code, nothing prevents somebody within a smaller system, such as in a team, to adopt concussion guidelines and do the shared decision-making process that I will explain to you later to make a difference in your smaller community. Then the physical environment is the last factor to look at, according to Finch. So our physical environment is so conducive to proper medical care that it almost feels like cheating, because Qatar is a really small country, and as you can see there on the graphic, it fits a number of times into the size of Switzerland. Of course, it is not in Switzerland, it's in the Middle East, but just to show the size. Our hospital is the reference center for all sports injuries in the country for registered athletes, and it's quite centrally situated. To be honest, it's within an hour's drive from any given club in the country, so it's perfectly situated. And to make things even better is that all team physicians, team physiotherapists, nurses and all healthcare workers in the National Sports Medicine program in Qatar, who are the team doctors in these federations and clubs, are employed by Aspetar. So they are all our colleagues. And obviously this is the low-hanging fruit. All we need to do is to provide them with the correct tools and information to go ahead and implement this program. So The Aspetar Sport Concussion Program was introduced after some colleagues here at Aspetar identified low reporting rates of concussion in the Qatar Stars League. And they postulated that this may be due to a lack of understanding of concussion amongst the healthcare providers and I guess the players and the technical staff as well, rather than a real low incidence of concussion. So we went ahead and, of course, we used the Concussion in Sport Group consensus as reference, and we used the IPARAS framework to identify 6 key focus areas of continuous quality improvement. And these are awareness and education, very importantly in our environment, cultural adaptation of concussion tools, but also educational tools and educational methods for good uptake in our society, in our culture. Network development, as I've mentioned before, of course, proper injury surveillance, customized clinical guidelines and services, and management processes to make this thing work. And that through inputs and processes will have outcomes, hopefully, in a successful sport-related concussion program, but also other spin-offs, such as customized educational tools and assessment material. This, of course, is underpinned by continuous feedback from all stakeholders and continuous improvement. So just to share with you some specifics of our program concerning awareness and education, for the non-medical population, we focused on club management, coaches and players and referees, but also parents and teachers by means of slideshows, pamphlets, posters, and also for the club doctors to use informed consent forms for concussion care, and all that underpinned by our position statement. I want to say something about our social media campaign, which is rather extensive. This is a customized social media program. It's not just loose Twitter and YouTube social media work. It's customized for Middle Eastern athletes for the best possible uptake. And I have to here acknowledge the key role of the Aspetar marketing department with their team of specialists who knows exactly how to get the correct message across in the correct way to reach the correct population. It is absolutely key to the success of such a program. So in terms of awareness and education for healthcare providers, we have continuous workshops, CPD meetings, and also a very popular monthly lecture series where experts come and address us on the latest trends in concussion care. The response has been very positive, and we can definitely see an attitude change as well as a reporting change. Our network is wide. Of course, you need a clinical referral network, but it's also essential to create partnerships with organized sports. In our case, the Qatar Football Association and the Qatar Stars League are the key role players here. And looking forward to the international FIFA events that are coming our way, we've also been liaising closely with FIFA. In terms of quality improvement, we have forged collaborations with various academic and research centers that you can see there on the slides. So baseline testing is really important, as I've spoken about before, but we've soon found out that the English SCAT5 is just not useful in an Arabic-speaking culture and population. So we went ahead and translated and culturally adapted the SCAT5. And I can tell you that this work is not merely putting this document from one language to another. There's a much deeper involvement and much deeper thinking going into this. Few simple examples. Feeling in a fog, which is a key question in the symptom score of the SCAT-5, doesn't mean a thing to somebody living in the Middle East. And neither does counting or naming the months of the year backwards make any sense to somebody who uses the lunar calendar and only uses numbering of the months of the year. To move on to the immediate post-injury stage, of course, that focuses on recognize, remove, and pitch side assessment and monitoring. The key here is we also translated and made freely available the concussion recognition tool, especially to referees and coaches and everybody involved in the various leagues in the country. The remove from play is always a sticky situation, and it can be challenging for various reasons. The injury may not be witnessed. Athletes are often unwilling to report symptoms. There's invariably pressure from team management or somewhere else to keep a player on the field just because of different points of view on what's important in a match. And obviously, there's often inadequate time for a team medical officer to assess a player and to make a definitive diagnosis of concussion. So we recommended, of course, increased awareness and education, but pre-season adoption of a sport-related concussion management plan by athletes, medical staff, and coaching staff, according to the occasion model, which Raouf has alluded to earlier. And that works more or less like this. So the occasion stands for, at the top there, you can see organization, coach at the bottom, and in the middle, athlete, decision-making. And you start at the very top. At policymaker level, at the highest level that you can get to, that might be responsive to education, and educate them well. Hopefully this will lead into a policy in your system, in your club, or in your federation. And with a policy in hand, it's much easier to approach the team management and the coach, where the doctor and the coaching staff can then make a shared decision on how this policy is implemented in this team. And with a combined force of coaching staff and medical staff, one then approaches the athlete and the team, educate the players collectively and individually, and then come to a shared decision about concussion management, hopefully with written consent in the end by the coaches and the players alike. Of course, this happens long before the start of the season to get this out of the way. We've prepared informed consent forms for those happy to sign that the doctor may be allowed to do proper concussion care right there in the heat of the moment. In the first 24 hours, we've designed a decision-making flowchart so that everybody in the system knows exactly when to refer an athlete to what, and what is the best possible place for a concussed athlete to be. Pitch side assessment, we have key documents. We're using, of course, the flowchart, but the SCAT-5 in Arabic and English. We make use of the Buffalo Concussion Physical Examination as vestibulo-ocular, cervical, and neurological examination tool. We've also designed a template referral letter to make sure that referrals are adequate and the information that goes with the concussed athlete is adequate. And for those who are discharged home under supervised care, we've designed an information leaflet to guide people on how to monitor at home. And of course, we're using the Berlin consensus for the rest of the treatment, just pointing out that we chose to use the CNS vital signs computerized neurocognitive tool because it's available in a variety of languages, which is conducive to our multicultural society. And we are widely professing the return to play protocol as proposed by the Concussion and Sport Group. Now, this last blue block is really key, as I've said before, and we are very focused on peer review through our own scientific committee, regular reports to the management of our hospital, and also we've submitted ourselves to external peer review this year to benchmark our efforts with what's going on in the rest of the world. Also, review and quality control cannot go without research, but just to point out that we do a peer-reviewed research, but only informed by the clinical needs of the Aspetar Sport Concussion Program. So very pointed research in areas that we really need it. And you can see the topics that we've chosen at this stage on the slide there. So to me, the key success factors are these, and as Raouf has also said, fail to prepare is prepare to fail. One needs to understand the people and the context in which you are working before you even start implementing your program. Education means everything. The more people know, the less resistance there will be to change. One needs to work on buy-in from all stakeholders. You start with a low-hanging fruit, yes, but if you don't have buy-in from everybody in the sport, including management and policy making and so on, then it'll be a tough battle. And for this, you need to be resilient and persistent. It takes really long time sometimes, but it's all worthwhile in the end. Of course, I've mentioned the continuous review to see what works and be honest with yourself and what's not working, and be flexible and adapt. I have to thank my team for carrying me in implementing this rather eloquent program. Thank you very much, John.
Thank you, Louis. What a great example of implementation and knowledge translation. I think we've really learned a lot from you and your colleagues' presentation this evening. So thanks for putting all that work in. I see we are at the top of the hour. How long do we have to go through a little bit of discussion and interaction with the panel?
John, I think we can use discretion, but maybe we can use another 10-15 minutes. Great.
Okay, so if the speakers are present, if you can turn on your microphones and your cameras, and we can have a little bit of interactive discussion around some of the key points that were raised. I think it'll be very useful. So welcome everybody to the end of the discussion, and thank you very much for your preparation and presentations. I think one of the key issues which arose from this series of discussions was how important it is to have a framework in which to operate, and good policy is very, very important. Carolyn, you've got a lot of experience in terms of the research that you've done in forming policy in your universities, your teams, and perhaps even nationally. Can you just perhaps elaborate a little bit on how you use research to inform policy, and perhaps the need for policy to inform your research as well?
Yeah, thanks so much, John, and thanks for including me in this symposium. I think that the key thing is understanding who the decision makers are, and really engaging those individuals in discussion early on in the research process, because I think that's how you get buy-in to sort of making the evidence-informed decisions, both locally, provincially, and in our case, and nationally. So involving them, and that's really the integrated knowledge translation process, I think, is really important, and continuing to get their feedback.
get their feedback on the research, and make sure that we're hitting the target in terms of what their priorities are. And for example, our focus on unintended consequences is really crucial to Hockey Canada and the provincial organizations. So doing that work that will inform best practice and policy in their context, I think, is important, and that engagement and ongoing engagement throughout the process. And when they make decisions that aren't evidence informed, making sure they understand that those are not evidence informed decisions, and continuing that conversation. And certainly we've come a long way in ice hockey in Canada, and I think they're looking to the research to inform their best decisions going forward around concussion.
Fantastic. I'm going to switch over to Leigh. Leigh, being involved in rugby union at various levels of the game, you're aware of the scrutiny that the game has been under in terms of being the collision sport with probably the highest incidence of concussion. What do you see as the key interventions that the game has made, World Rugby in particular, that has made the game safer, in your opinion?
Thanks, John, and thanks for the opportunity to talk about what World Rugby has been able to do. So I think if I have to summarize it, our main key policy changes that have resulted in the safer game and reducing the incidence of concussion is certainly the ability to change the laws of the game to allow for that 12-minute pitch side assessment. And allowing players to return if they've passed that. The mandating that recognize and remove for in a non-elite situation, so that has been mandated. And again, then how the sanctions have changed. So sanctioning the high tackles, sanctioning dangerous tackles, so what World Rugby has seen is that if you are wanting to make changes, there has to be an ongoing recognition of reaction to those changes. So it's no good just suggesting something and hoping that it works. Actually, it's taking a proactive approach from the beginning. And Martin Rattray and Ina Felvey, the CMO for World Rugby, have done a lovely editorial in one of the recent BJSMs about talking about compliance wedges, which is it's a subtle tool that World Rugby approaches from the beginning when they want to implement a change, really where they are encouraging when something is changing, that it's making a difference, and putting player welfare as a priority and as a business priority for the federation has really made a very big impact there. And again, going back to what research is doing, when there's been a lot of accusations and heated debate about the safety of rugby, it's been we've been able to answer that with evidence-based as opposed to emotion. So looking at what the evidence is at how effective the HIH Protocol has been at reducing concussion, and so really taking that emotional part of the discussion away, because obviously all your potentially catastrophic and fatal injuries, it becomes a very emotive and emotional subject.
So I think consistent in your and Carolyn's answers are the need for evidence-based to make decisions. And I think that really makes the need for pointed research in the field that much more important. And the outcomes of these consensus meetings and the research that builds towards them is absolutely critical. Louis, you heard Leigh talk a little bit about the 12-minute period that rugby union has to assess players. You also spoke about football, soccer being a little bit behind, perhaps. You alluded to that. Do you think there's a place for rule changes in the game of soccer to try and allow our colleagues to evaluate players a little bit more effectively, rather than the sort of 3-minute period they have now on field?
Yes, definitely, John. To be honest, football seems to be very slow and reluctant to embrace concussion care, and they're years behind what's been done in rugby and also in ice hockey. So as you said, the 3-minute rule is there, and it's not actually enforced in all instances. And to be honest, it's not enough. in 3 minutes' time, you can make a mistake or not, and in the end, often the decision of the team doctor is overruled in any case. So I think more rigorous enforcement of strict policy is really necessary in football. They've come a long way in the last year or so, and started trying some things, of which the 3-minute rule is one. But they've also introduced concussion spotters, independent venue medical officers, similar to the match day doctors in rugby, who can assist and advise the team physicians. And also they've introduced independent concussion assessment specialist services at the international FIFA events. So there is some movement, but doubtful if it's enough.
Okay, so certainly some change in the positive direction. Rauf, I'm going to ask you two questions in one. Firstly, the SCAT tools we spoke to. How familiar are your colleagues in club football with those tools? Are they in regular use? And if you had the opportunity to ask for some more support around your concussion network, what would that be?
Okay, first for the tools, especially the SCAT5, I think now we are used since few years to use these tools. Of course, some doctors will use it more than others. Some doctors started with the baseline testing using these tools for their healthy football players. Some others waited to have some concussed players to be more aware about the importance of this. But the last 2 years, I think everyone is skilled and have the good knowledge to practice these tests, not only the doctors, but also the physiotherapists. Regarding your question, who should we need to support us? I think not only FIFA, but the national federations. Why? Because you know that we receive in our clubs coaches from different locations in the world with different backgrounds. And in my presentation, I talked about 3 challenges. One related to myself as a doctor, one related to my player, but I could say that the player is coming to a club, he's accustomed to listen to the coach, to the manager, perhaps to the doctor, but the coach, no. So I think sometimes when you have a coach who will say for you a concussion is like a contusion, he has just to support some pain. He considers it like this, he doesn't understand what is it. You have to make some work to transfer your knowledge in an adequate way from a healthcare provider to a coach. So I think the support of the National Federation with the coaches and the referees will be very helpful to be accepted for that, so that the coach have already an idea or some baseline information on this topic, and he will receive more. I mean, because I remember my own experience like 10 or 9 years ago with the coach. When I wanted to present and to talk about the concussion, he refused. He initially accepted, but when he saw the presentation with a video of concussed player, he told me, no, I like the English players with blood from their nose, and they continue to play, to fight, they don't care. So it's, you know, the image, this kind of thinking. So then I understood that it's not only the mistake of the coach, but because I have to use some better skills in communication to convince him, to make him understand what's the concussion. It's not the contusion on the bone, that's it. So with years, I learned how to talk to the coach, even though who are reluctant to accept this situation, to change the player, even if he seems normal to the coach. He don't see a player unable to walk because of a doctor grade 3 tear or hamstring injury. So I think things are getting better, but we still need the support of FIFA and National Federation.
Okay, very, very good points. That the challenges that are facing doctors at all levels. Carolyn, back to you. If you had to identify some of the key areas you think need research in sport-related concussion, to help us really answer some of those critical questions out there, what would they be?
Well, probably no surprise to you, John. I'm going to say that there's a lot more we can do upstream to have a bigger impact, certainly in the non-elite levels of the game. So I think, and when we look across all sports, congratulations on all the work all of you are doing in rugby, because you're way ahead of the curve and using the evidence and moving that forward. I think that certainly across targets of related to rules of the game and also the impact of referees, for example, in that context, equipment in certainly some sports more than others, as well as training strategies is going to be really critical. And then I would also say that where we're focused a lot, particularly in youth, sport-related concussion is on the treatment end of things as well, and preventing consequences of concussion. We really have very few trials out there, and I think that's an area where all of us can work together collaboratively to really have a larger impact than we've had to date, certainly getting the right treatment to the right individual at the right time. So.
Brilliant. And perhaps, Leigh, a last question for you. You spoke about one of the high-profile areas of rugby evaluation, certainly in the professional game, and that's the HIA, the head injury assessment. Now, the visible portion of that is the player being removed from the field for 12 minutes and either coming back to the field having been cleared or not. But often people perceive that to be the concussion test and that it's over. Perhaps if you could just emphasize that that's only the beginning of a process, and that the HIA really is just the first window into how that player is and what happens after that, just to emphasize that it's an ongoing process of serial evaluations.
Absolutely, John. So, and I think it's also important to note that a lot more sports are becoming aware of our protocols and our assessment, and you'll often hear people commentating saying, oh, he should be taken off for a concussion assessment, where actually not realizing that a lot of the other sports don't have that facility built into their sports. So there's some way to go there. So when a player gets removed, as we talked about having that baseline SCAT5, what we first do is a very abbreviated version of that SCAT, or elements of the SCAT5, and that gets compared to their baseline. So as I said, if you've had definite signs and symptoms and you've removed, that's actually that's the beginning of there's your diagnosis, and your management is taken on from there. But not everything is evident immediately. So that first assessment is really an assessment for suspected concussion. And then the HIA2 is the next assessment after that, which is a more formal assessment. Also, again, going through the elements of the SCAT5, a clinical evaluation, reviewing your video footage, and then the person examining them is skilled and experienced in those multiple domains of examination. So examining vestibular symptom, your vestibular system, your balance system, and really you get a feel for the subtleties of concussion symptoms in those players. So that again it's a time element, because a lot of your symptoms can evolve. They're not apparent immediately, and they can evolve over time. So that HIA2 is really within 90 minutes. And then again, your symptoms can evolve over the next 24 hours. So the next aspect of that, the HIA3, is really a repeat evaluation. Gives you more chance to look at things in greater depth and detail, looking at your VOMs that you mentioned earlier, other aspects, repeating a neurocognitive test depending on what your baseline is. So really it's an evolutionary assessment, which we're using multiple domains and looking at it over time, because we know that those symptoms can the symptoms can develop over time, but also the players may not report things immediately. They might deny their symptoms completely in the beginning because they want to go back on the field. And then afterwards they go, oh, doc, yeah, I did feel quite dizzy on the field. I just didn't want to say something because I wanted to finish the game. So, their interpretation of their symptoms might be quite different from when you examine them in the middle of the game as opposed to at the end of the game. But really it's a serial evaluation, both clinically and then we have the the benefit of the video review as well. So if there are things that you want to go back and have a look, and how did he react? How did he react immediately in the next 5-10 seconds? We've got the privilege of doing that as well.
Okay, brilliant. Very well explained. And I think the take-home message there is that the same sort of format needs to apply at all levels of the game, that you don't just get assessed once on the side of the field and a decision is made. Those assessments need to be made over the course of time, and all those domains need to be assessed. So, Louis, I think in the interest of time, let's wrap it up. Let me firstly thank you for hosting us. Also, just to say, I think the key take-home messages today is that we need ongoing evidence to inform our decisions in sport-related concussion. We need robust and clear policy guidelines in all sports. We need protocols that emphasize a multidisciplinary, multi-domain and multi-time frame approach. And we really need to, as we're doing tonight, translate our knowledge and transfer our knowledge to all sectors who are involved in sport. And thank you for allowing us to do that this evening. So I'll let you sum up.
Yes, thank you, John. Thanks for this nice summary. So I guess all that remains for me is to conclude by thanking you for co-hosting, and also for our other panel members, Carolyn, Leigh, Raouf. It's been a privilege working with you and sharing the stage with you. I also want to thank the Aspetar Journal and the editor-in-chief, Professor Nebo Popovic, and his editorial manager, Ivan Stankovic, who made this opportunity possible for us. Very special thanks to the technical team, Rupert Ramos and his team. It's been special, Rupert. And of course, special thanks as well to Mrs. Emna Daghraoui, our operational manager, who made everything just tick. And of course, thanks to everybody who checked in and who signed in tonight. I trust that everybody has found a little gem to take with them on their concussion journey forward. I thank you very much and good night.